So hello everyone for the second session of our workshop on fundamentals in pediatric dialysis. So I would like to welcome you everyone, and Fabio, you can start with your presentation.
Okay, thank you, Stephanie, and good afternoon, everybody. I'm Fabio Paglialonga from Milan, and now we are talking about how dialysis works, and in detail, we will talk about how to manage solutes during dialysis and to remove fluids. Let's start with solutes. You know that several uremic toxins accumulate in CKD, which can be classified in three groups according to their molecular weight: small solutes below 500 Daltons, middle molecules like beta-2 microglobulin, and protein-bound uremic solutes. These three groups behave really different during dialysis. Dialysis requires a semi-permeable membrane, which basically is a biocompatible membrane with some pores. This membrane, just to give you an idea, has more or less a surface area similar to the body surface area of our patient. The membrane is arranged to form thousands of capillary hollow fibers, which are placed in the filter. And the fibers subdivide the filter in two compartments. The blood compartment inside the hollow fibers and the dialysate compartment outside. The clearance of a solute during dialysis depends on three main mechanisms: diffusion, convection, and adsorption. Adsorption has a very little role in pediatric dialysis at present, so we will focus mainly on diffusion and convection. Diffusion is the passage of a solute across the semi-permeable membrane according to a concentration gradient. So if you have two compartments with a semi-permeable membrane in the middle, all the solutes smaller than the pores will move from the high to the low concentration compartment till equilibrium. Diffusion is used in conventional hemodialysis, also known as bicarbonate dialysis, which consists in a standard extracorporeal circuit and in a dialysate circuit, which goes countercurrent compared to the blood. So in the filter, we have the membrane, which separates the blood and dialysate compartment. And all these substances, smaller than the pores, can move from one side to the other according to their concentration. Diffusion is highly dependent on the molecular weight of the toxins. So conventional hemodialysis is highly effective for small molecules, but much less when the molecular weight increases, and it is substantially unuseful for proteins. How to improve the clearance of a given toxin by diffusion? We can act on four factors. The first one is the concentration gradient, which is the difference between the plasma and dialysate concentration of the solute. It seems intuitive, but in the clinical practice, not so easy. If you look at the example of sodium, sodium is a very small molecule, 23 Daltons. But the dialysate sodium is usually set at 138, 140 milliequivalents per liter, but the pre-dialysis plasma sodium concentration of our patients is often lower than this threshold. This means that in many cases, the patients will take sodium by diffusion, and they will end dialysis with a positive sodium balance, which is not good for thirst and blood pressure. Blood flow is a very important parameter, as of course, the higher the blood flow, the better the clearance, at least for small molecules, of course. But to have a good blood flow, we need a very good vascular access, so an arteriovenous fistula whenever possible. Dialysate flow is important as well, as the higher the dialysate flow, the better the clearance, but once again, just for small molecules. But please remember that when the blood flow is low, below 200, which is very common in pediatric dialysis, it does not make sense to have to increase the dialysate flow too much because the clearance will not improve. And the fourth factor is the diffusive permeability of the membrane, which can be expressed with this parameter named KOA. KOA is basically, for a given patient, for a given substance, the maximum theoretical clearance that we can obtain at infinite blood flow and dialysate flow. It depends on two factors, K and A. K is the diffusion coefficient of a membrane, which basically expresses the permeability by diffusion of a specific membrane to a specific solute. It depends on the size and number of the pores and the thickness on the membrane as well. The area, the surface area, is important because the larger the surface, the higher the number of pores, and so the better the clearance for a specific blood flow. But once again, the blood flow is an important limiting factor, because if the blood flow is below 200, once again, it does not make sense to use a huge filter, because we will have an increased extracorporeal blood volume, but not an improved clearance. All these factors can be summarized looking at the clearance of the different substances. If you look at the fact sheet of each filter, you can look for each substance at its clearance for a specific filter and a specific blood flow and dialysate flow. Convection is a completely different story. It does not depend on concentration gradient, but it depends on the pressure gradient. So if you have two compartments with a semipermeable membrane in the middle, if we apply a pressure on one side, we obtain a movement of water across the membrane. But water does not move alone. It will drag the solutes if they are smaller than the pores, once again. Convection is used in hemofiltration, which consists in a standard extracorporeal circuit, but we do not have any dialysate flow. What we have is the pressure applied across the membrane, which generates an ultrafiltration. And the ultrafiltration means always water plus solutes. And the ultrafiltrate is substituted by replacement fluid infused either pre-filter or post-filter. From the difference between the concentration of the solute in the ultrafiltrate and the concentration of the solute in the replacement fluid, we have the effect of dialysis on this specific solute. Pre-dilution and post-dilution are not the same thing. If you use pre-dilution, the blood entering the filter will be diluted. This is good for the filter because the clotting probability is reduced, but this will reduce the efficiency of the treatment, because the plasma water entering the filter will be diluted, and the ultrafiltrate will contain a lower concentration of toxins. So we will need many more liters of replacement fluids to obtain the same effect. Hemofiltration is rarely used as intermittent modality in chronic kidney disease patients. What we usually do is hemodifiltration, with the combination of diffusion and convection. Basically, you have the same standard extracorporeal circuit. We have the dialysis circuit, which goes countercurrent compared to the blood, so we have diffusion, but we also have an ultrafiltrate, which is substituted by replacement fluid infused either pre or post filter. The modern dialysis machines do not use bags for dialysate and replacement fluids, but they produce these fluids online directly from the osmotic water. And please note that the replacement fluid will go directly into the patient's blood. So if it contains even a minimal amount of antitoxin or other microbiological agents, this is not good for the patient. So it is really important to be sure of the quality of the water. If you are not sure that your water is ultra pure, please don't do HDF. The convective clearance of a toxin during convective modalities is basically the product of two parameters, the sieving coefficient and the convective volume. The sieving coefficient is a measure of the convective permeability of a membrane to a specific solute. It goes from 0 to 1. Basically, 1 means that the solute is free to pass across the membrane. 0 means that the substance is not dialysable. Sieving coefficient is dependent on the molecular weight, of course, but in a less strong way compared to the diffusion coefficient. Convective volume is the main determinant of the dose of dialysis in convective modalities. We aim to reach a target convective volume of 12-15 liters per square meter per session post-dilution mode. The convective volume is basically the product of the transmembrane pressure and the ultrafiltration coefficient. The TMP, the transmembrane pressure, is the pressure applied across the membrane to generate the ultrafiltration. And the ultrafiltration coefficient is a measure of the permeability of the membrane, not to solute, but to water. If the ultrafiltration coefficient is high, this means that this membrane can generate a huge amount of ultrafiltration with a small TMP. And high flux filters are therefore very useful for convective modalities. If you look at the fact sheet of each filter, you can easily find the ultrafiltration coefficient and the sieving coefficient. The modern dialysis machines can automatically adapt the TMP to the characteristic of the membrane and to the characteristics of the patient to keep the convective volume as high as possible. But of course, the ultrafiltration can be just a proportion of the plasma water entering the filter. So it will depend on the blood flow and on hematocrit and total protein content of the blood. Sorry. So once again, the blood flow is basically the main determinant of the convective volume. And so vascular access is a critical point. Which are the differences between convection and diffusion? Diffusion is perfect for small molecules, and which basically are the majority of the substances that we routinely measure in our daily clinical practice. So it is very common that if we look at the blood tests of our patients, we can comment, wow, the patient is very well dialyzed because urea and phosphates are perfectly under control. But please don't forget that several uremic toxins are larger or have a middle molecular weight, so they are not effective at all by diffusion. In these cases, we need convection. From a clinical point of view, please look at this beautiful study published a couple of years ago by Rukhsana, which is the 3H study, the HDF ART and height study. It is a non-randomized prospective observational study which involved both prevalent incident patients treated with thrice-weekly conventional hemodialysis or thrice-weekly high-volume post-dilution online HDF. 190 children were enrolled, and the primary endpoints were intima media thickness and height SDS. After 1 year, the patients treated with HDF had a lower intima media thickness and better height SDS compared with those treated with conventional hemodialysis. So the conclusion is that HDF is associated with better cardiovascular protection and better growth in children. And in the same study, HDF was also associated with a lot of other potential advantages, including lower pulse-wave velocity, lower left ventricular mass index, lower blood pressure levels, lower interdialytic weight gain, better dialysis tolerance, lower levels of beta-2 microglobulin, which is a marker of middle molecules, lower inflammatory status, and a more favorable metabolic bone profile. So the take-home message is HDF is now the standard of care for children needing chronic extracorporeal dialysis. But as well shown in this couple of studies published by Evelyn, please remember that neither conventional hemodialysis nor hemodiafiltration are able to remove protein-bound solutes. And we have a lot of toxins in this group. The only way to remove them is by your kidneys. So the take-home message, once again, is even after the start of dialysis, it is important to preserve residual kidney function. And let's move to fluid. What happens when we prescribe a net ultrafiltration to our patients? First of all, we have a refill of fluids from the interstitium into the blood compartment, which depends on the oncotic pressure, so total protein, albumin levels, and hydrostatic pressure, so fluid overload. But if the ultrafiltration rate exceeds the refill capacity with a reduction in blood volume, and the first compensatory mechanism is a shift of blood from the venous blood in the splanchnic area into the systemic circulation. And actually, if we measure the red blood cell content in the abdomen during dialysis, you can see that if the ultrafiltration is 0, these parameters remain constant. But if we prescribe an ultrafiltration, the red blood cell content of the abdomen reduces at the beginning of dialysis to compensate for the reduction of blood volume. Other compensatory mechanisms are much less effective. Many people think that vasoconstriction is a good compensatory mechanism to avoid hypotension during dialysis. This is not the case because actually hemodialysis usually generates an increase in body temperature, which is associated with vasodilatation, not vasoconstriction. So there is nothing to do. If the ultrafiltration rate exceeds, is too much, what we have is a reduce in blood volume, a reduced venous return to the heart, and a reduced cardiac output, which eventually can lead to organ hypoperfusion, symptoms, and hypotension. But even in the case of a completely asymptomatic session, we may have significant organ hypoperfusion, which may involve the brain with even cognitive problems in the long term, the liver with possible detoxification problems, the kidneys with a loss of residual kidney function, the intestine with bacterial translocation, and of course the myocardium. At the myocardium level, we may have myocardial stenosis, which is a segmental transitory decrease of myocardial contractility, which is completely asymptomatic, but it is very, very common during even asymptomatic session. And if repeated more and more times, it can lead to myocardial hibernation and myocardial fibrosis. So the message is just increasing the ultrafiltration rate to clinically tolerated is not a good strategy. We need to avoid organ hypoperfusion, but to do that, we need to measure blood volume, and we can do it because the modern machines actually can measure the hemoglobin levels or total protein levels, and thus they can calculate the percentage change in blood volume of the patient all over the session, and this machine can give you a curve like that, showing you the percentage change of blood volume of the patient. And if the blood volume decreases too fast, this means that the ultrafiltration rate is excessive, even the patient is completely asymptomatic. And we need to reduce the ultrafiltration rate. Of course, if we reduce the ultrafiltration rate, we may expose our patients to the risk of post-dialysis fluid overload, which is no better than pre-dialysis fluid overload. How to manage this problem? The best way is to reduce the interdialytic weight gain, and so to reduce the need for ultrafiltration. We suggest to keep it below 4% of body weight, so an ultrafiltration rate of less than 10 mL per kilo per hour. But to obtain this result, what we can do is just to increase the number of sessions per week, or better, to improve the sodium balance, because there is a very strong association between the interdialytic weight gain and the sodium balance of our patients. Basically, our patients drink because they eat salt, and water goes always where sodium goes. To conclude, I would like to emphasize the main important points, in my opinion. Good vascular access to improve clearance, and so please pay attention to the Ruxana's talk in a few minutes. Blood volume monitoring to avoid excessive volume contraction during dialysis, and convection added to diffusion in HDF to improve several patients' outcomes. And thank you so much for your attention.
Good afternoon, everyone. I hope you can see my screen. Thank you, Fabio, for your excellent talk. And I will continue the session about daily management in the hemodialysis unit. My name is Evelien Snowart. I'm a pediatric nephrologist at Ghent University Hospital in Belgium. These are the objectives of my talk. I will start with a short introduction, and then I will discuss the considerations when starting hemodialysis. Thereafter, I will go through the main aspects of dialysis adequacy and summarize complications that occur during hemodialysis. Thereafter, I will briefly touch upon the importance of multidisciplinary care, and I will end with some take-home messages. In my opinion, daily management in the pediatric HD unit really feels like a tug of war. On one hand, we aim for an adequate correction of the uremic environment by offering sufficient dialysis time, by prescribing medications and dietary restrictions. However, on the other hand, the full package of hemodialysis treatment is seriously hampering the quality of life of those children and families. Moreover, participation in society and life is limited, and they are missing so much time at school and at home. And daily management in the HD unit really keeps us balancing between those two while really striving for the best long-term outcomes in these patients. When you start a child on hemodialysis, I would say there are two golden rules. And the first rule is start slow, and especially start slow to prevent dialysis disequilibrium syndrome, or DDS. DDS is a very rare neurological complication that is most commonly affecting patients during that first hemodialysis session. Studies have shown that cerebral edema develops due to intracerebral fluid shifts driven by changes in intravascular solid concentrations during HD. Patients at risk are those children with pre-existing neurological conditions, high urea levels, hypernatremia, hyperglycemia, and metabolic acidosis. Those children often present with headache, nausea, and vomiting. And I think the key here is really prevention by avoiding this rapid fluid and osmotic shifts. So how to do that? Start slow, use a very low blood flow to start with, not more than 3 mL per kilogram. Have a very short first session of, for example, 2 hours. Have low UF goals to start with. And if you have a high-risk patient, also consider to decrease also the osmotic shifts by adding mannitol as well. The second rule in starting dialysis is to be around at that first hemodialysis session, and also to keep an eye in the following sessions in that initial period. During that first session, you have a child and a parent who is always stressed. It's something new. They don't know what to expect. It's also sometimes a fistula who has to be needled for the first time. So it's really up to the team to really make the transition as smooth as possible by preparing the families, the child with your play therapist or psychologist, Having familiar faces also around during that first session, or having your play therapist there to give distraction and support to the child. You also need to reassess your medication list at that first session, but also in the sessions afterwards, you probably will need to do some changes there as well. And then I think you really have to go through all aspects of your hemodialysis prescription very frequently all over again. For example, your vascular access, we have the tendency to have our vascular specialists around, doing the ultrasound, helping with the nurses to decide where the needling area should be. And then we also assess our blood flows obtained with our vascular access. But of course, you also have to reassess anticoagulation therapy, your symptoms of your patient, volume management, and labs. After this initial period, of course, your daily management will shift to a focus on hemodialysis adequacy. But the big question is, how is adequate hemodialysis defined? And historically, KTOVV was proposed as marker of hemodialysis. And currently, more than 30 years later, we really lack the evidence to support the use of KTOVV in our practice. Moreover, the validity in the pediatric population is unknown, and the KTOVV goals in children are not really defined. How can we explain the fact that KTOVV is not really a good marker of adequate hemodialysis? And to explain that, you need to understand that dialysis adequacy, from a more solid perspective then, is really governed by, on one hand, what is happening in the dialyzer, and on the other hand, what is happening in our patient. If we look to solid transport in the dialyzer, then we look to the blood flow, the membrane characteristics, and also the dialysate flow. And now we are talking about clearances of solutes and extraction ratios. Inside the patient's body, on the other hand, solids are distributed over different compartments, and the sum of all these compartments are going to define the total distribution volume of a particular solute. How fast the solute can be transported from the deeper tissue to the plasmatic compartment, where it can be removed by the dialyzer, is defined by the intercompartmental clearance. To calculate an intercompartmental clearance and a volume of distribution, we use kinetic studies, where we are going to really calculate the total amount of solute that is removed during one session from the patient. As dialysis is only clearing the plasmatic compartment, your solute removal will be limited in solutes with a very large volume of distribution, and also in the solutes who have a very slow intercompartmental clearance. If we look to the perspective of the dialyzer, so the right side, then we see that every solute is going to behave differently, which is also explained already by Fabio. Where you see that diffusion is a strategy that is mainly important for the small molecules, and is also the only way the free fraction of protein boundary endotoxins can be removed. If you compare with the middle molecules like beta-2 microglobulin, then you have a significant advantage of adding convection to your therapy to be able to remove these middle molecules at the dialyzer. If you look to our patient, and you see that these kinetic studies have learned us that the intercompartmental clearance and the volume of distribution of each individual toxin is very, very variable. If you look to urea here on top of the figure, you see that the intercompartmental clearance is very high, which means that urea can very quickly be mobilized from the deeper tissue to the plasma. If you then look to beta-2 microglobulin, then you can see that the intercompartmental clearance is only 6% of that of urea. In other words, the shift from the deeper tissues to the plasmatic compartment is very slow for that molecule. Therefore, solutes like beta-2 microglobulin, they really need time to allow recruitment of these solids from the deeper tissue. I hope somehow showing you this data is that I can convince you that solid removal is not only about our dialysis machine and dialyzer, but also depending on the patient the machine is connecting to. And I also hope that I kind of also can convince you that KTOVV is a parameter that should be interpreted with caution. As I showed you before, urea kinetics is not representative of the kinetics of other solutes, make it almost self-evident that urea clearance is a poor predictor of many aspects of dialysis adequacy. Therefore, I think that's also the trend that you see over time, is that the definition of adequate hemodialysis have shifted to more patient-relevant parameters. And that's also, I think, what we should focus on. Adequate hemodialysis really means a child in a good nutritional state and optimal growth. The child who is normotensive, euvolemic, without frequent IDH, so intradialytic hypotension episodes, and a preserved residual kidney function. The child with normal calcium phosphate and PTH levels who are adequate without metabolic acidosis and a normal serum potassium. You need to have hematological control with also a good anticoagulation strategy without clotting or bleeding. And of course, I think this is a central part that we'll discuss by Roxana in the next talk. That is also, I think, the crucial part to obtain the previous aspects, is to have a good long-lasting access as well. And of course, the last one is the symptoms. We really want to have the symptoms of our patients to be low. We want to have sufficient psychosocial support, and also sufficient time also for the patients, the children, to have education and attendance at school. And I think I really want to stress that an adequate hemodialysis is really something dynamic. It's not something that you just assess in the beginning. It's something that you need to do all over again and again and again. You have to reassess and reassess. And to come back to my introduction, it's really a balance sometimes between all these aspects. Sometimes you have to really try to find a good balance between all these things, that the patient is still on board. I'm not going to go through all these factors. I don't have the time to go through everything, and some of the things are going to be discussed also in the next talks as well. So I'm just going to pick some of these to highlight. Children with poor nutrition and growth really have the worst long-term outcomes with respect to survival, hospitalization rates, and morbidity. So therefore, I think close follow-up to nutritional state with a renal dietitian on board is an essential piece of the daily management in the HD unit. Next to nutrition, there are, of course, several other factors that contribute to growth failure and protein energy wasting, like shown also in this figure, like metabolic acidosis, fluid overload, endocrine disorder like vitamin calcium phosphate, or growth hormone resistance. So you need to consider all these aspects in that management as well. If you want to have your child growing on hemodialysis, you really need to optimize nutrition. And if this is optimized, you can consider growth hormone therapy as well. You need to correct calcium phosphate and PTH and metabolic acidosis. You have to optimize your blood flow, which is of course related to your access. You need to optimize your dialyzer and also dialysate flow. And of course, if you're not getting there, optimizing time is also an important aspect to consider, which is also shown by Dr. Fischbach in the past, that by increasing your time on dialysis, that you really can obtain and reach catch up growth in your children. And I really think that if your child is growing, that you can say that you're doing a good job, because I think really growth is the best marker of dialysis adequacy in pediatrics. I've summarized here also some recommendations that have been published in the last couple of years, which I think are very practical in our daily management for your reference as well. A second important part of dialysis adequacy is, of course, your cardiovascular disease management. We know that cardiovascular disease remains the most important cause of death in our pediatric dialysis population. And we know that this cardiovascular disease management really plays a crucial role in our management. Key is really optimizing these cardiovascular outcomes while really striving the adequate volume management, which really is defined by having a normal blood pressure with no or minimal antihypertensive agents and no left ventricle hypertrophy. And this is also really highlighted by Fabio in the previous talk. And I really think this is like the main topic that we need to focus on. Of course, calcium phosphate PTH is again important here. And we also want to avoid intradialytic hypotension. In the volume management, central piece of that is, of course, your dry weight assessment. Dry weight assessment in children is difficult, and it's quite challenging because it's something that is also more like a moving target that needs frequent reassessment. There are a couple of tools that really can guide you in this dry weight assessment, and of course, key is your blood pressure, and in the best way with an ambulatory blood pressure measurement. You also can use your BCM and also your RBV, so your relative blood volume monitoring. That's also explained by Fabio before. I want to show you this study as well. It's from the adults, but I think it's really, important study. It's from the DOPS, where they looked through all different centers across Europe and also Australia and other centers. And they looked to the outcomes, cardiovascular outcomes and mortality on the center level. And what they saw is that centers who have protocols that specify how frequent and how you should address by weight assessment, that those centers have overall the best outcomes in terms of cardiovascular morbidity and mortality. Instead, you see that on the other hand, that only using, for instance, the online volume indicator is not really giving an benefit for the patient on the long run. So I would really stress that it's important to have this have a strategy in your dialysis unit that specified how you're going to assess your dry weight. And in that team, you need your dietitian on board to really have your patient adhering to the dietary salt restriction, because that's going to result in lower intradiabetic weight gain and lower UF goals, so that we don't have this IDH events. And IDH, I want to add here as well, because intradiabetic hypotension is the most common complication that we have in our hemodialysis unit, and it's defined by a low blood pressure below the 5th percentile of age, and symptoms giving an action like fluid bolus of stopping of UF. It's giving quite some symptoms to our patients. It can cause myocardial stunning, cerebral hypoperfusion, and also decline in renal kidney function. Also very important to realize is that by stopping UF, by stopping your dialysis session earlier, in the end, you will have your patient chronically fluid overloaded, but also a reduced solid clearance in the end. And we know that patients who are frequently having these episodes have the worst outcomes. And this is Aldo Delta, where they see that the mortality increased significantly in the patients who have frequent ABH events. When I was a fellow in CKIDS, we performed a nice study on that topic, where we initiated a new multidisciplinary meeting, with a dry weight meeting, having a dietitian, the nurses, and the fellows, and also the dialysis physician there. And during these team discussions, we discussed the difficult patients who had frequent IDH, who has problems in terms of hypertension, hypotension. We also had this education program in these meetings incorporated to have all the members of the team there. And we also worked on an embedded tool having all the information of BCM, RBVs, weight, pre and post dialysis in one screen in our electronic health records. And having implemented it all together, we could really decrease the number of IDH events in our hemodialysis unit from 16% at the beginning to 8% after a period of 6 months. We also saw a drop in our antihypertensive agent use as well. So I really would like to share you that really changing the culture and the policy on volume management can really benefit our patients. So I will jump now to the complications that can occur during hemodialysis, and I talked already a lot on IDH, I think after every IDH event, you really should assess again your volume management and assess your dry weight again. But there are also a lot of more rare complications that I think I need to at least mention here. And the first one I talked already before, so it's the disequilibrium that we can treat with mannitol. Also, a rare complication that can happen is the anaphylactic reaction to the dialyzer, which is often present already very shortly after initiation of your dialysis session, with hypotension, angioedema, pulmonary symptoms, and chest pain. Sometimes also urticaria, fever, and others. Always try to stop your dialysis session quickly, and don't give the blood back to your patient, and treat, of course, with epinephrine, and if needed, also hydrocortisone. Also, two other very rare complications that can occur is, of course, hemolysis. Hemolysis is often a very severe complication where the patient will present with malaise, weakness, nausea, and abdominal pain. Of course, with current more modern machines, this complication should be picked up quite quickly by the optical sensor in the machines. When you have that, of course, stop your dialysis session and always don't give the blood back and check your serum potassium because you can have very severe hyperkalemia. Also, an important rare complication is air embolism. These patients are often also critical and acutely sick with cough, chest pain, and shortness of breath. Clamp the source of the air if possible and turn your patient on the left side with head down. And I think especially for these last two, I think prevention is really key. You really have to have your standard operating procedures with your dialysis nurses to really make sure that these complications cannot occur, because they are often related to the setup of your machine, because its connection it's always related to that. So I think prevention is really key here. So beside all these medical aspects of dialysis adequacy, we also have to realize that also multiple other factors will determine the health of the children and adolescents on dialysis. And this is a figure from a recent paper published in Nature Reviews that highlights the dimensions of children's health and rights beyond these medical aspects. And children and adolescents, and even more our children in dialysis, are very vulnerable to the negative effects of social determinants of health, which really determines also their lifelong health capabilities and also of their subsequent generations as well. Dialysis have a very significant impact on our children's rights to good education, recreational time to thrive, and others. Also, poverty is often exacerbated in our families with a child on chronic dialysis, and often parents need to reduce work to make the treatment possible. And also, I really want to stress the importance of parental health and education in the health of the child, because these parents are at risk for anxiety and depression. And it's really important as caregivers to also create a framework that is able to support the parents as well, because that is also going to benefit our patients. So therefore, I think a multidisciplinary team in the pediatric dialysis unit is essential to enhance the holistic view of a child's health, far beyond also the medical aspects who are there. So this brings me to the end of my talk. The main messages I would like to leave you with are: start slow and be around when you start hemodialysis in a patient. Consider patient-relevant clinical outcomes to define adequate hemodialysis. And I think a pediatric growth is probably the best marker of dialysis adequacy. Do not forget the story of slow-moving solutes in the fast hemodialysis machine. And I think key is continuous reassessment of all aspects of adequacy. And it really takes a multidisciplinary team to really raise a child on chronic dialysis. Thank you for your attention, and I'm happy to answer your questions at the end of the session. Thank you. I will give the word to Roxana.
Thank you very much, Evelyn and Fabio. Can you all hear me? Excellent. Thank you. I'll just start sharing my screen. Sorry, I'm in a hotel room in Leuven, so just slightly strange surroundings. I can't get my slides up. Can you give me the share slide permission, please?
We are already seeing your slides, so you can go on the presenter.
Oh, you can see my slides. Amazing. Thank you. Thank you. Can you see my first slide?
Yes.
Perfect. Thank you very much. Okay, so hello, everyone. And thank you to Justine for organizing this excellent symposium. So I'll be talking to you about catheters and fistulas for chronic hemodialysis. Fabio and Evelyn have already set the scene for this, stressing how important vascular access is. So what would you prefer, a central venous line or an arteriovenous fistula? Let us look at the pros and cons of these and also very briefly touch on arteriovenous grafts. I'll then tell you about a one-stop vascular access clinic that we have set up, and then the optimal care of arteriovenous fistulas. The principle throughout this work is vascular access preservation, and I cannot stress this enough. We must remember that even when our children grow up and move into the adult world, they will need access for their future dialysis. And it is essential that we provide good access for them and preserve their vessels for the long term. My talk is going to focus around these guidelines for pediatric vascular access. As a European Society Dialysis Working Group, we produced these guidelines in 2019, and everything that I go through today will be focused on the guideline statements, but giving you a practical aspect of that work. So in 2008, the International Pediatric Fistula First Initiative was launched. And when we look at what has happened in the 20 odd years since then, we see that the prevalence of CVLs, central venous lines, is still extremely high at almost 85%, with a much smaller prevalence, in fact, of AV fistulas and a little more of AV grafts. Now, these data come from Nephritix in North America. So let us see what is actually happening in Europe. The International Pediatric Hemodialysis Network, led by Klaus Schmidt, produced this excellent survey in 2019. They looked at 552 patients on chronic HD or HDF from 55 dialysis units in 27 countries and with 5-year data. And here you see that the number of patients divided stratified by age group and the type of access they have. So in blue are the central venous lines, in red the arteriovenous fistulas, and then a very small prevalence of arteriovenous grafts. The overall prevalence in Europe, therefore, is about 60% of our patients have central venous catheters and 38% arteriovenous fistulas. This is better than the statistics from North America. But you must keep in mind that even in older children, even in the 10 to 15-year-olds, where a fistula formation is theoretically easier and feasible, there is still an unacceptably high use of CVLs. And the reason I'm going to tell you a little more about why I think CVLs are such a bad choice. So here you see the different types of central venous lines and the access sites. Now remember, a CVL should not be placed in the subclavian vein because there's a very high risk of subclavian stenosis, which therefore of course means central stenosis, and the survival of a future CVL or even a fistula will be jeopardized by this. We do have lines in the right internal jugular and very rarely in the femoral, and femoral access again is not acceptable and not advisable because there is a easy risk of contamination, and then of course your future site of fitting in a kidney transplant can be affected. The risks with central venous lines are many. There's a higher risk of infection, poor dialysis adequacy, and poor blood flows, hospitalization, thrombosis, and even death. In the talk earlier, Fabio stressed to you the importance of blood flow for good dialysis clearance. And therefore, once again, we come back to the critical aspect of excellent dialysis access to improve dialysis clearances. This study has shown, from North America, has shown that when you compare a vascular catheter or a central venous line with an AVF, there's a higher risk of hospitalization, a higher risk of infection-related hospitalization, almost 4.7-fold higher, and a 2.7-fold increased risk of access complications. And there are many, many such papers which will give similar data. The IPHN registry has shown that primary patency and secondary patency are both much higher for the AV fistula in green in both the graphs compared to the central venous lines in red here. And again, stressing how important good access is. To me, the single most important reason why central venous lines are so bad is what you see in this picture. You see a very young child with lots of dilated veins on their chest wall, several scars of a previous access insertion, and a swollen face from superior vena cava obstruction syndrome. And when we did angiograms on this patient, it's really what you don't see, which is so important. You don't see any of the central vessels bringing blood into the heart, and rather a very large number of collaterals. So central access can be lost even in a very young child if we are not careful with our access strategy. Now, this brings us very nicely to a vascular access clinic. So about 15 years ago, we set up a vascular access team comprising an access surgeon, myself as the pediatric nephrologist, a vascular technologist or somebody who can perform very high resolution ultrasound scans, and our dialysis nurse. And together we developed this one-stop process for education, for access assessment and access surveillance. Now, our vascular access strategy was to see the patient early, to stress the importance of vein preservation, to use the non-dominant before the dominant arm, to go distal before proximal, and native before graft, so before AVG, and to try and avoid central venous lines where possible. By seeing the patient early, we recommend that they're seen before their GFR, when their GFR is sort of dropping just below 30, with no age and no weight limit for this. And the importance is to discuss the options for different types of dialysis and the types of access options, to stress vein preservation, and to begin psychological preparation for the young child when they need fistula cannulation. And vein preservation is so important because, as you see, even in this picture, somebody is taking blood from the antecubital fossa, and this sort of practice must really be stopped. Venous assessment includes both clinical and ultrasound based. On clinical assessment, we see the patient in a warm room so that there isn't peripheral vasoconstriction. We review the peripheral and the central veins and look at the vein for its size, dilatation, continuity, length, the straightness of it, and the depth of it. And we assess both with and without a tourniquet to see the maximum diameter of this vein when with the tourniquet applied. We then have an ultrasound performed, and this is a sort of graphical image on which data is recorded. So here again, you see two sort of spaces for vein size at each level, and this is with and without tourniquet. And we examine the veins along the entire length of the arm and also central veins on ultrasound. But keeping in mind that central vein assessment by ultrasound is difficult because you cannot look behind the clavicle with an ultrasound scan. And for pediatric considerations, of course, the bigger the vein, the better your outcome is likely to be. But veins of more than 2.5 millimeters and arteries of more than 1.5 millimeters are considered adequate. Now, looking after your AV fistula and the cannulation technique is extremely important. Again, we want to stress the preservation of central access, and in cannulation, particularly in our young patients, gaining the confidence of the child and parent is essential. So you want to prevent aneurysms, you want to prevent an infiltration or a blowout of the fistula, and of course, by preventing damage to the fistula walls, you hopefully can prevent stenosis and then subsequent hemorrhage, thrombosis, and infection risk. There are three different techniques of fistula cannulation: the ladder technique, the rope, or also called rope ladder technique. And here you will see that the access into this is at different lengths along the fistula. Keeping in mind, of course, that your two needles must have an adequate distance between them to prevent recirculation. I won't read out each and every one of these points, but this is the principle of ladder technique compared to buttonhole technique. In buttonhole technique, you can see there are two discrete entry points into the fistula, and what one tries to do is to actually develop these points by repeated cannulation at the same spot, the same angle and the same depth, ideally by the same cannulator for several initial sessions of dialysis. And once this is established, then what happens is that it becomes easy to then perform blunt cannulation at a later stage. And with the blunt cannulation, the pain and the discomfort to the child is reduced. An important aspect of buttonhole cannulation is that there will be a scab formation over the sites. And with the scab formation, particularly in children who can tend to pick at the scabs, there can be an increased risk of infection. So if you have a child who's at risk of staph infections, then do be careful with this. Area puncture is another important point, and here with area puncture, it's rather than a buttonhole, it's in discrete areas along the length of the fistula, as you see here, and there can be multiple entry points into this. Unfortunately, this increases the risk of aneurysm formation and weakens the wall of the fistula, so it's not really a recommended process. Now, one of the key aspects of this is psychological preparation. And indeed, in very young children, and we perform vascular access with fistulas, even in children as young as 2 years of age, it's extremely important that psychological preparation is performed. And this is with play therapy, with coping techniques. You see all of these different things here, with adhering to a strict sort of protocol agreed with the child and their parent, and the experience of the cannulator to gain trust in them, particularly in the initial sessions. The first cannulation and the timing of this is really important. This very nice study from Germany has looked at the timing to first cannulation and access survival. And what they've shown is that cannulation before 30 days is more likely to lead to access problems and future patency compared to cannulation after 30 days. And excuse me. And in fact, based on this, they recommend that you should not use the fistula in its first 30 days after creation, and ideally wait until 45 days for this. Looking after the AV fistula and surveillance is extremely important. I've listed this as an ABCD, but of course you don't follow exactly this order. But we would check dialysis adequacy, the blood flow rate, clinical problems reported, and this could include something such as prolonged bleeding after removing the fistula needles, diagnostic imaging with ultrasound, looking at the dialysis parameters for clearance and for recirculation, and actually examination. Now, all of these different factors should be performed each time, and it is suggested by our ESPN guideline as well as by European best practice guidelines that 3 to 6 monthly surveillance is performed. And remember, this is in a healthy fistula, not when you encounter problems. The surveillance risk factors things that should alert your attention to investigating further is a reduction in blood flow, usually by about 25%. And the absolute levels for this are reduced blood flows in a fistula of less than 400 mils a minute, or in a graft of less than 600 mils per minute. Causes of AVF loss include a large number of factors, mainly thrombosis in the fistula, but also stenosis, infections, bleeding, reduced blood flow, and rarely aneurysms and the Steele syndrome. Steele is extremely rare in children compared to in the older adults, where they can have a peripheral vascular disease that can increase the risk of Steele syndrome. So access survival, as per our IPHN data, and as you I'm sure will predict, the optimal survival is in an AV fistula compared to a CVL. Now for this analysis, fistulas and grafts are combined together, but as you see, there's a distinct improvement in survival with fistulas compared to grafts. The predictors of patency for fistulas and grafts, and the primary as well as secondary patency, was studied by this group from the Midwest in the US, and they saw that access patency in a combination of fistulas and grafts was clearly superior in the fistulas, and an intervention-free survival was the only predictor of secondary patency. This slide is very important to me, and this is data from the ERADTA ESPN registry. So here they looked at the number of access changes required. So these dotted lines in this red or orange is for fistulas, and the dotted line in blue is for central venous catheters. And as you see, central venous catheters are much more likely to require change. In fact, 91% more likely to need change as compared to central venous catheters. So again, the patency of these access is important, but central venous lines do so much worse. And if you have to talk to your managers and convince them about optimal access, clearly they look at euros and dollars only. So here, looking at the prevalent hemodialysis patients as well as incident patients, you see that the costs for AV fistulas are significantly lower than AV grafts or central venous catheters. In the bright red here is the cost of access-related radiology and surveillance for these fistulas. And this is, of course, this is for prevalent access. For incident access, you will see the cost of access surgery is higher with AV fistulas, but significantly more for grafts, where more money is required to for expensive AVG devices. And therefore, it's almost a no-brainer for your manager to consider that an AV fistula is substantially cheaper in the long term. So we've talked a lot about the pros and cons of vascular access. To summarize it on a slide here, I've told you a lot of the benefits of AV fistulas, including superior blood flows and patency. But just very quickly, AV fistulas are not suitable in the smallest children, and really there's no definition of how small is small. It depends on the weight and really on the vein size more than anything else. And of course, your surgical expertise of your center determines this. The AV fistula needs time to mature. You can't use it for acute dialysis access. There is needling pain, which must be acknowledged, and the child supported with this. There can be cosmetic features surrounding this that must be considered, and you can have high output cardiac failure and Steele syndrome, but they're not common. In contrast, we've talked about CVLs, and on this occasion, I've told you all the disadvantages of CVLs. But of course, one must acknowledge that CVLs can be used in the youngest children. Size is not that important compared to AV fistulas. Immediate access is provided, and then it's pain-free, needle-free access. So you have to choose the right access for the patient at the right time, and keeping in mind preservation of access at all times. We put this poster up in all our dialysis clinics now: save your veins, save your life. And we've taught children and their parents they're the best protectors of their own vessels to say no to needling in the antecubital fossa, and as best as possible needling for blood taking and for cannula insertion only on the dorsum of the hand. For more details, I'm going to shamelessly promote our own course, which is called Advances in Pediatric Dialysis, and will follow on from this course we are doing right now, which is the basics of dialysis for junior doctors. This course is for doctors, dialysis, and nurses, and it's on the 10th and 11th of February next year. So with this, thank you all very much indeed, and I'm happy to take questions. Thank you. So I think at this stage, yeah, we need Fabio, Evelyn, and myself together as the three people who've done this session. And again, I encourage all of you to please post your questions to us, put them in the question section in the tab on the right-hand side, and we'll be delighted to start a discussion on this. So perhaps I can start this discussion and start by asking Fabio, Fabio, 1 minute. I'm going to start by asking Evelyn. So Evelyn, you told us a lot about blood volume monitoring and managing intradialytic hypertension by assessing patients carefully. A question here is, could you tell us about the different tools available to assess optimal weight? And then if IVC, inferior vena cava collapsibility, is a good option for this.
Yeah, I think there are different parameters that you can use. I think the pitfall is always to only base on one. I think you really have to incorporate a different blood pressure clinical assessment. You can use BVM, you can use BCM. You can also, if you have experience, also use the inferior vena cava collapsibility index. I would really advise to use different parameters, integrate them together, and follow them over time. Which is probably depending on the expertise that you have in your center and the tools that you have available. That will be, I don't think there's one superior to another. I think it's really incorporation of multiple factors in that decision.
Yeah, absolutely. And yeah. Absolutely, and particularly in the youngest children, it is indeed difficult, isn't it, to get anything like BVM, because BVM is not possible in the smallest hemodialysis lines on the infant catheters, and also doing something like impedance and bioimpedance analysis is not possible in the youngest infants. But thank you. Fabio, we have a very good question here asking about loop diuretics to preserve residual renal function. Would you recommend that?
Absolutely, yes. If there is some residual kidney function, it is well demonstrated by some randomized controlled trials in the adult population that if we treat the patient with residual kidney function diuretics after
I can't hear you now, Fabio. Oh, yeah.
Yeah, I would encourage to try with loop diuretics in children with residual kidney function too. But of course, it is important to assess the efficacy of our treatment. So what we usually do is to look at residual kidney function, the urine output, basically to start furosemide and to assess if residual urine output increases significantly. In this case, it would be important to continue this treatment because it can preserve residual kidney function and help in reducing interdialytic weight gain.
Thank you, Fabio. Absolutely, we do the same. Absolutely. I'm going to ask myself a question now from the list of questions here. So this is asking about how long, what period of time with a central venous line is acceptable when preparing for transplantation? And this is a really important and good question. It's difficult to define a time, but given the fact that AV fistulas need maturation time, we, as a rough figure, have said if a child is scheduled to have a living donor transplant from a relative within the next 6 months, then we would not place an AV fistula, perform an AV fistula surgery. This is a rough figure, but remember that if you have a child who's going onto a waiting list for transplant, and there's the unpredictability of when they will get their kidney, then this becomes a much more difficult issue. Of course, you know the local waiting times in your countries. Some parts of Europe are extremely fortunate with very, very short waiting times for children, whereas many other countries, including the UK and I'm sure Germany as well, have a much more difficult time getting kidneys on a deceased donor list. In this situation, remember that one line can lead to another from complications, and before you know it, you perform multiple central venous lines in little patients. And equally, patients can get quite comfortable with their CVL and not want to go through another operation, not want to consider the pain of needling. So many factors to bring into discussion here. And it's important to prepare patients who do not have a living donor kidney option for access types. Yeah. Let us move on. And a question on acute dialysis. So Evelyn, you've told us very nicely that if a child, how to manage the first dialysis sessions, but there are questions here about children who may have crash landed onto hemodialysis with a very high urea level. You said go slow. Can you give us a few more details about how you manage this, please?
Yes, start slow. I think it's on different aspects. So I would really start with a very low QB, and I wouldn't go more than 3 mL per kilo per minute. If a child is really coming in with such a high urea, I would even consider to use a smaller dialyzer in comparison with the surface area of your patient to have lower clearances as well. You even can decrease your dialysis flow if you want as well. So I would really start slow, and you could do it with different aspects: blood flow, dialysis flow. I think that's the most important aspect. About the ultrafiltration, I think it depends on the patient. If the patient can wait a bit, you can do it after starting and maybe the next session. If you really have severe fluid overload, then you can start, but then also don't start with big goals, but you start with a low UF and see where you can get, and then you can build further on in the next sessions.
Okay, thank you, Evelyn. Very quick answer to this question. How do you use potassium chloride during acute HD? Potassium chloride during an acute HD session? I think the answer is usually no, but it'll depend on serum potassium, isn't it? It's Fabio, for you, when and how do you prescribe the diuretics?
Great question. As I told you before, I started with a trial diuretic therapy if the child has some residual kidney function, some residual urine output, and we usually start with a single morning dose of around 3 milligrams per kilo per day of furosemide. We know that the dose should be higher than those needed for children with normal kidney function. So we start with this kind of dose, and then we monitor residual urine output in the next days to verify if it works or not.
Thank you. Absolutely. So just very quickly, to a couple of quick questions I'm going to answer on access type. Do we use pre-puncture anesthetic cream like EMLA? Yes, absolutely. I would recommend it. In fact, in some cases, even a quick puff on a gas would be effective, and some centers do that. A question of when is the first access puncture of an AV fistula. I did show you that paper which says don't puncture the fistula before the first 45 days, definitely not the first 30 days. We know from our IPHN registry that the first access puncture is usually around 8 weeks, and that is absolutely acceptable. It is beyond 45 days, right? Next question is there's the AV fistula needling technique. In our center, we do prefer buttonhole technique, but actually when you first start off with a new AV fistula and you're just defining what the best puncture sites are and getting a patient used to it, you may be performing rope ladder in the initial stage, then moving on to a buttonhole technique. And there are lots and lots of very interested questions, but I think in the interest of time, we really do have to stop at this stage, and we must move on now to a case presentation. So we have Katarinska, and I'm sorry if I haven't said your name correctly, Katarinska, but thank you very much for preparing an excellent case. We look forward to hearing that now. So this case is, Katarinska is a ERCNet fellow who has worked in Krakow, and she's going to present this case to us now for discussion after that. Thank you, Katarinska.
Hello, do you hear me?
Yeah, yes, perfectly. Thank you.
Yeah, I try to show my presentation. Okay, to show the first slide.
Yes, we can see that. Do you want to put it on full screen, please?
Yes, sure. Thank you. Sorry for my small problem. Yes, I will do.
Don't worry, take your time. And if you can switch on your camera, if you can.
Yeah, I can switch because I think it's not necessary to see me, but to see the presentation. Thank you very much for accepting this. It's a true story, and we just actually have still problem with this patient. So I'll be very grateful. Sorry, I'm just trying to show you the full screen.
Are you okay there? Can you hear me?
I think she's offline, so maybe something into her connection, or I don't know.
Okay.
If you want, you can continue with a question from the question box, or
Yes, that's a good idea. So that we have a few more minutes. Oh, okay. Are you there, Katrinska?
no, she's still offline.
She's still offline. Okay, then let's, as you say, let's use the time for a couple more questions. Just tell me when she's back, please. Yeah.
I'm back.
Oh, you're back. Okay, lovely.
Yeah,
Thank
sorry,
you for
excuse
joining.
me, that's the table. Okay, so sorry,
Don't
thank you very. Yeah, can I start?
Yes, please do.
Okay,
Thank you.
so
Please do.
pediatric nephrologist from Krakow, and I'm working in dialysis unit for many years. And thank you very much for your time and for looking at our patient. So of course it was prepared by me, but many doctors are working with this guy. So this is actually now 4 years old boy with congenital renal failure and recurrent problems, infections related to catheter, different catheters you will see, and also adverse reactions to antibiotics. Yeah, well, I'm just trying to move to the next one. Okay. So his perinatal and neonatal history. He is the first child of the healthy parents. He was born as a small premature, which you see the birth weight, and prenatally he was diagnosed to had oligohydramnion, and also there was some prenatally intervention with shunt insertion into urine bladder because the dysplastic kidneys, both sides, were found. After birth, he was in quite severe condition. He required respiratory insufficiency, required nitric oxide and mechanical ventilation. And what was confirmed that he had urethral atresia and bilateral dysplastic kidneys, and also one pelvic was dilated in the right kidney. He, to make possible to have urine output, there was just insertion of a big needle to his urine bladder as a temporary solution, and he improved very quickly with his pulmonary function, and the normal urine bladder was preserved. And he was transferred from peri-neonatology unit to our intensive care neonatal unit. Then he was not so bad. At the age of 5 weeks, the vesicostomy modobloxom was created by our colleagues. And of course, he had the features of congenital renal failure, but he didn't require starting dialysis at once. We diagnosed that the one kidney's function, only one, the right one, and of course, what we suspect that he had high refluxes, both sides. At the age of 2 months, his eGFR was approximately 20 milliliter per minute, and he required conservative treatment of chronic renal failure, but his urine output was normal. And he had vesicostomy, but I have to admit that urinary tract infection he had only once in his life. What was the problem from the birth? That was recurrence of vomiting and poor weight gain. We tried feeding by nasogastric tube. That's true. We didn't did gastrostomy because there were one hole for the urination, which was just from urine bladder. But finally, because we thought maybe when we started dialysis, it would be better for him and he would his weight will gain better. Then we started peritoneal dialysis at the age of 17 months. And still he has his normal urine output, so we didn't need to dehydrate him. And additional problem he has is a hip dysplasia. And then our problems has started. So please, maybe it's not important to look at all these details, but look that he had during 1 year and a half, 6 episodes of peritonitis. And the first peritonitis was just after insertion of the catheter, and many of these peritonitis were sterile, so we didn't find the bacteria, and many of these peritonitis were without very high cytosis, and he was not in very bad condition, but still we had to treat with antibiotics, of course, mainly intraperitoneally if it was possible. Then we, after a few months, we decided to exchange the PD catheter. There were 2 episodes of exit site infection, and this exchange of PD catheter was complicated by hypervolemia and also by catheter tip dislocation. So he required again laparoscopy with fixation of the catheter to the anterior abdominal wall. And unfortunately, after a few months, again, he developed next episode of peritonitis, next episode of exit site infection, and at the end, after 6 episodes of peritonitis with no improvement after our treatment, we had really great problem with the dialysis culture. So we didn't find the cause, but still the cytosis increased and he started to have clinical problem and of course abdominal pain. So we decided, he was at this age approximately 3 years, so we decided to change for hemodialysis. At the beginning, it was just like always during New Year's Eve day, but finally it was done. So we removed his dialysis catheter, Tenkov catheter, and we inserted, our surgeon inserted permanent catheter on the right side. But it was complicated by bleeding, but it was I think surgically mistake, because they were probably given too big dose of heparin intracatheter, which should go to the bloodstream, and that's why he started bleeding massively. But we treated him quite quickly, so finally he left our hospital with this permanent catheter. Unfortunately, 3 months later, he came back with catheter-related sepsis and exit site infection. So we treated this, and there is appeared again another problem, which I didn't mention before, that his reaction to many antibiotics, which I gather in the next slide, was really severe. So they were allergic or close to allergic, and it requires from us more slower dosage of antibiotics and giving antihistaminic drugs. Finally, after treatment, we didn't exchange the catheter. It was, as you see here, methicillin-resistant Staphylococci epidermidis type. And after 4 months, he again came with episodes of sepsis. And also it was they found Pseudomonas aeruginosa, which was found from the exit side, but there were another staphylococci found in blood. So we treated him. We also used some antibiotic log, but we after we thought we finished, but unfortunately day after he came back with again sepsis and again with urticaria symptoms, very massive and starting appearing very quickly, but it was just skin changing. Fortunately, he didn't have full anaphylactic shock, and we treated him again with vancomycin and all these antihistaminic drug agents, steroids. And we decided to remove this catheter and insertion a new catheter after 2 days. So we did this with a break between. So we removed the catheter, we have the sterile blood culture, and then we put another catheter 3 days later. And unfortunately, after 1 week, again, we have situation with positive blood culture and again urticaria. So we treated the new catheter with vancomycin and gentamicin log, antibiotic log. And I know it looks terrible, but it happened that after 3 weeks, again, he developed fever, urticaria, and catheter-related sepsis, which from this point, he's still now in the hospital. It's just the end of August. And we treated him. It was with a high PTC, procalcitonin level, CRP level. We treated him with general antibiotics. Fortunately, he improved very quickly. And then we continue with antibiotic log. And unfortunately, what is a very big problem with his clinical stable condition, no symptoms, low CRP, low procalcitonin, and without any general antibiotic, we still have positive blood culture from his catheter. So now we decided to exchange the catheter again, to put the acute one, treat him with antibiotics, and change to the permanent catheter, because we didn't want to come back to peritoneal dialysis. What I have to admit, of course, we look for any other infection sources by computer tomography and any other consultation. Nothing was found. Also, we consult him by immunologists and other allergologists, and they didn't help. Okay, for a while he was on subcutaneous immunoglobulin supplementation, but now his immunoglobulins level are okay. And here you have summary of his adverse reaction to antibiotic we go through during all his clinical course. So it's not maybe important, but look that apart from his infectious, he has the reaction. So the treatment of him is extremely difficult. Even he reacted to catheter lock, intraperitoneal, and also when we gave to vancomycin to his vascular catheter, we had the reaction. Later, no. I'm sure you asked me.
Yeah, thank you. No, sorry. The last slide.
Just two more things, because you probably asked me why he was not transplanted. So I want to answer that he was more than 2 years on waiting list. Then there is no possibility of living donor transplantation from any of the family because of the different blood group. And also I tried to prepare him for cross transplantation. It was impossible. And now he will be on the urgent list, but it will be when we will have clean blood culture. Okay, and this is my question, and greetings from him. This is Cuba in the middle when he has his 4 years for his birthday. He had in our hospital in our dialysis unit. Thank you very much, and sorry for a long time. Thank you.
No problem. Well, thank you, Catherine. That was a very interesting discussion and certainly an extremely challenging case. So we have lots of questions from interested people. And I think maybe we can start with a question from Justine, which I also have on the top of my mind, is an immunological assessment for this child. Is he immunodeficient, either with inherited or acquired immune deficiency?
No, he was consulted by our immunologist, and they did the screening of the cellular response and also by immunoglobulins, which were lower. Immunoglobulins level were lower when he was on peritoneal dialysis. So that time he was on supplementation, what I just mentioned. But now that's okay, and they say he doesn't need any more help from that point of view, their point of view.
Oh, it's in itself interesting that he needed immunoglobulins. I'm not aware of any patients on HD needing immunoglobulins other than for an immune deficiency reason. Did your immunologist actually check his response to different vaccines as well? Did he make responses to vaccines? Was he in that sense healthy?
I think they did. Okay, telling the truth, I have no prepared answer, detailed answer now, but that's true. He was consulted, maybe not in few recent days now, but he was consulted before, and they say they prepare. They what they suggested us. They suggest to give immunoglobulin during this peritoneal dialysis period only, not now.
Okay, thank you. So he had a number of episodes of sterile peritonitis.
Yes.
With this happening, I have two questions that come to mind. One is, did you talk to your microbiology laboratory about saying there's a high white count in the PD fluid and the child is presenting with sepsis? Why is the PD fluid sterile? Is it a laboratory error? Did you discuss that?
Yes, we discussed, but telling the truth, majority of this peritonitis was not very severe, so they were not so high cytosis, and he was not in very bad condition, if I can compare to my experience with different patients. So, but of course we discussed the way of taking the dialysate, because of course in our hospital it depends on the time, but we discussed all these details. But
Okay.
the problem was that he went home with good condition, and weeks or 2 weeks later he came back with increased cytosis, and we had to do something. Yeah.
So on this note, a question that comes from in my mind is,
yes.
If you have a high white count and sterile peritonitis, did you check for eosinophilic peritonitis? And this is also what Sevcan says from Turkey in the question session, because this is she's the lead for our IPPN peritonitis guidelines. Did you check for eosinophilic peritonitis?
Yes. Of course, the truth is we checked, and he also had eosinophilia in blood from his very early beginning. We also consulted him with hematologist in the early beginning, because it was from beginning he must have reacted much more expressive than the other children, because we saw it. I'm convinced that to every foreign part he has in his body, he will react. But what we can do, we don't know, because nobody gave us any.
Did you have a high IgE count in his blood?
Not so
and
high.
Did you try
higher, but not
higher.
Very high. Yeah, a little
higher.
bit.
And have you tried treatment with sodium chromoglycate or montelukast for eosinophilic peritonitis?
No, we didn't. He's on very big dose on this antihistaminic drug, because when the urticaria appeared, they helped us, our allergologist, to give a very high dose of rupafin. Okay, very high dose, and that's true. He is now on this. And on small dose of steroids, he was on higher dose of steroids, but recently.
So in the interest of time, I'm going to just a few points which I can see here on the suggestions from people coming through on the questions, with Sevcan offering very good advice as well. There's omalizumab you can consider in addition to the in addition or a secondary to the montelukast. Also there are questions about training the family, about having dedicated PD nurses, and about having refresher training courses for the parents to perform PD. To be honest, I think this might be more likely to be a case of eosinophilic peritonitis that your child had, so it's well worth considering treatment for that. But one important thing to exclude is atypical peritonitis infections and atypical organisms such as Mycobacterium tuberculosis and atypical mycobacteria as well.
Yeah.
I'm going to just ask if there are other panel members. I'm sorry if I can't see you all at this moment, but Fabio, Evelyn, Klaus, is anyone else on the panel, and would you like to offer any comments? because we are running over time and we must close now in a couple of minutes. Yeah, Ariane, thank you. Any suggestions? Evelyn, Fabio, any suggestions?
I was wondering about the nutritional state. How is the growth chart of this child? Because I think this is also an important factor to optimize, because a good nutrition will also help to decrease infections and.
Absolutely.
Yeah, absolutely. Yes, we did gastrostomy, but he's mainly fed now by nasogastrial tube. So finally, he is smaller for his age, but he's growing. On HD, it was much better than on PD. So that's why I'm very afraid about coming back to PD now.
Thank you. Fabio and Ariane, any comments? No. Okay, but thank you. That was a very interesting case. Thank you again for presenting it. Lots of very interesting discussions. And I hope your child gets that transplant soon.
Yeah, that's me too.
Yes, indeed. So with these comments, then I think, Justine, do you want to close the session, or perhaps in the interest of, yeah?
Can you hear me?
Yes, we can hear you,
Yes.
Justine. Thank you.
Yeah, okay. So thank you, Roxana, for leading this part of the discussion. I think indeed it's time to close the session and to ask you to come back tomorrow at 2 p.m. For a new exciting session. And I hope you enjoyed this afternoon. Please send us your comments and suggestions if you have any. And in the meantime, have a great evening and see you all tomorrow. Bye-bye.
Thank you. Bye, everyone. Bye.
Thank you very much for all comments. Thank you.
Thank you.